Hello. This is Beginner's Colonoscopy. Today's presentation is a compilation of anatomical observations I've learned through trial and error during endoscopic procedures, small but practical insights. I hope this video will be of some help to all of you. Let's begin. Lubrication is more important than anatomical knowledge when it comes to colonoscopy. In my practice, I apply lubricating gel along the first 20 centimeters of the endoscope shaft before starting the procedure. Gasgol, which many of us consider merely a foam-reducing agent, is actually much more than a simple gas eliminator. It contains Simethicone, making it a top-tier lubricant as well. If you feel resistance during insertion, before worrying about anatomical issues, try spraying a small amount of Gasgol mixed water onto the endoscope shaft. For non-sedated patients or those with dry mucosa, I often start by spraying Simethicone solution into the rectum from the beginning. In diagrams, the rectum appears to rise vertically, but in reality, it doesn't. The rectum actually travels a considerable distance in the anterior-posterior direction and takes on much more varied shapes than we might expect. Without understanding rectal anatomy, I used to simply push and pull the endoscope. However, once I broke free from that mindset, I started treating the anus like a laparoscopic device port, using it as a pivot point to manipulate the scope in all directions. This approach not only allowed for much more versatile access but also significantly reduced difficult cases. If you want to shorten the colon, it's crucial to reduce air from the rectum onward. You might be surprised at how long the colon can become when filled with air. In my early days, I found that the more easily I could advance into the sigmoid colon, the more I struggled with loop formation. When you advance from the rectum into the sigmoid without significant resistance, the sigmoid tends to overextend, creating a sharp bend in the distal portion. An overextended sigmoid colon typically shifts to the left and often forms a reverse alpha loop. In these cases, gentle pressure on the left upper abdomen can help shorten the sigmoid colon. With a long sigmoid colon, you'll find that simply jiggling the scope slowly at various angles, without much pushing, allows the tip to gradually advance. These small incremental movements are often the key to smooth passage. The sigmoid-descending junction is the most difficult area to navigate, often causing pain and complications. In patients with a large abdomen, loops may not resolve, and the SDJ may not open at all. In these situations, simply inserting a folded towel or piece of clothing into the left flank can meaningfully change the angle of the sigmoid-descending junction, making passage much easier. The splenic flexure is generally approached using leftward torque. While it's usually a manageable section, it can sometimes become the most challenging obstacle. In particular, if you've been performing gastroscopy for a long time, residual air in the stomach can compress the splenic flexure and transverse colon, hindering advancement. Simply removing enough air during the gastroscopy can significantly reduce the difficulty of colonoscope insertion. In thin women, the transverse colon often hangs down to the pelvic region. In these cases, gentle pressure on the lower abdomen helps. In obese patients, the transverse colon tends to pass through the upper abdomen instead. If you're pressing hard on the lower abdomen with no progress in the transverse colon, try applying gentle pressure around the navel or the upper abdomen instead. You'll often find much easier advancement. For the hepatic flexure, approach it like entering the second part of the duodenum, hook upward and apply rightward torque. If you can't advance from the hepatic flexure into the ascending colon, remember that the hepatic flexure has a three-dimensional folded shape. Gentle pressure on the right upper abdomen to unfold this bend makes insertion much easier. To enter the cecum, simultaneously apply rightward torque and downward leverage while suctioning air. Rather than pushing the endoscope in, you want to bring the cecum toward the scope. If there's too much gas in the small bowel causing significant distortion and preventing advancement, waiting a few hours before trying again might be the right answer. Large amounts of gas in the small intestine can significantly affect the structure and course of the colon. Colonoscopy is less about simply finding a path and more about adapting to each patient's unique anatomical situation. I hope today's insights prove helpful in your clinical practice. Thank you for watching until the end.